So I will talk today about our specialty medical home for inflammatory bowel diseases. And I appreciate the support from Dr. Rieder and Dr. Click on this, because this was born by Dr. Rieder at UPMC initially and then transferred to the Cleveland Clinic, and Dr. Rieder is now the head of our institute. So my disclosures. And the learning objectives for the next 30 minutes is to understand the concept of a patient-centered medical home as a new model of care, to describe the specialty medical home and how this differs from traditional IBD center of excellence. And I think a lot of this can be transferred to other chronic inflammatory diseases of the skin or rheumatologic diseases. And then we outline an emerging concept of medical neighborhoods and the potential for specialty population health. I'm going to introduce to you the economic burden of IBD, since most of you will be dermatologists or rheumatologists. 1.6 million Americans are affected, and they cost annually 14 to 31 billion to the United States. Crohn's disease on average about 25,000 per patient, and you see between 15 and 20,000 per patient per year. Prior to the biologic era in 1998, which is when anti-TNF entered inflammatory bowel diseases, inpatient care was the major driver of costs, but post-biologics, biologics are the cost driver for inflammatory bowel diseases. In addition, these patients experience productivity loss, Crohn's disease more than in ulcerative colitis, but between 20 and 40% of the patients have that. And why would we actually consider specialty medical homes? And when you evaluate the national health expenditures as the share of the gross domestic product, this graph is all familiar to you. They're increasing healthcare costs over time, and now close to 20% of the gross domestic product are spent on healthcare. And the major factor of this, the high cost of care, are rare and chronic diseases, and inflammatory bowel disease is a chronic disease. So when you think about building a medical home, conceptually it was born in a pediatric population. It is to promote coordinated inpatient and outpatient care across a defined population. And the attributes of a medical home, and you will see this throughout the next 20-25 minutes, is accessibility, comprehensive coordinated care, compassionate, culturally sensitive, patient and family-centered, and it's a team-based delivery. And it's considered fundamental, if you think about alternative payment models, to promote this type of care in a medical home. And it simultaneously is patient-centric, and it is also population-oriented. The focus of medical homes, and for sure when you start one, but this will likely stay the focus for a while, are the so-called super utilizers. So a small proportion of patients that account for the majority of the spending in inflammatory bowel disease, but also in other chronic immune-mediated diseases. The top 25% of IBD patients account for 80% of the spending. The highest 2% account for more than 1/3 of the total spending. So if you focus on this population, the gain you can have is major. Factors associated with high use, in this case in primary care, is comorbid conditions, limited access to care, unstable medical relationships, and mental health disorders. So we are wondering, what about inflammatory bowel diseases, and what are factors associated with high utilization? In the table, you see the top 10 costs for IBD patients, and this is post-biologic era. Number 1 and 2 are mostly biologics, pharmacy and injectable drugs, so biologic costs. Number 3, emergency room and hospital. But across all of these cost drivers for inflammatory bowel disease patients, the psychosocial impact has a strong influence on driving individual costs. And I mentioned earlier, a small proportion of patients has a large impact on health expenditures, and this is our own population, where you see that about 30% of the patients account for close to 80% of the costs. And the major drivers here, it's mental health and pain that drives unplanned care, optimizing biologics and surgical intervention. So if you target these top 30%, you can target 80% of the healthcare expenditures. But in IBD, what factors are associated with future increased expenditures? So which populations do you target for a medical home? And in this study, 2,078 patients were examined, and you see on the bottom the patients, and they are ordered by the number of dollars they had spent between 2009 and 2013 in terms of healthcare costs. Total charges, 214 million across these 2,000 patients. When you compare the median 300 patients that costed 4.5 million to the top 100 patients that costed 95 million, and broken down to per patient, 14,000 per patient in the median group, 691,000 in the high utilizing group. And the drivers that distinguish high utilizers that you see in dark blue versus medium utilizers that you see in the light blue are psychologic comorbidities and other comorbidities such as hypertension and diabetes. The disease phenotype matters. So if you have perianal disease, which is a severe disease manifestation, in this case of Crohn's disease, if you have internal penetrating disease, which is connections between the bowel and the bladder, bowel and the skin, or bowel and the bowel. If you have extensive ulcerative colitis as opposed to limited disease extent of the bowel. But when you put this in a multivariate model and you see which characteristics are associated with high chargers, you find racial disparities, so minority races have higher costs. Unemployment is a cost driver, which are both healthcare disparities. Comorbid conditions such as depression, anxiety, which indicates difficulty to cope with the disease. Opiates, which indicates pain as a driving factor, and that came also out in prior specialty medical homes before it was established for inflammatory bowel diseases. And then disease severity, prior IBD surgery, penetrating disease, and use of corticosteroids. So the four big factors that drive healthcare utilization in IBD is disease severity, pain, healthcare disparity, and inability to cope. And when you focus on those, in the high utilizing patients, you may have the biggest gain to reduce overall healthcare costs. What complicates matter in chronic inflammatory diseases, including inflammatory bowel diseases, is the fractionation of care. And this is driven by behavioral conditions that impact medical response, impact adherence, unplanned care or quality of life. By IBD complications, IBD is not only in the bowel. Patients need care for anemia, they need care for vitamin deficiencies, they require a surgeon. And then healthcare maintenance. The vaccination schedule is different, bone health, and cancer screening. So multiple providers and sometimes multiple healthcare systems are needed to address all of these issues. And this combined with, for instance, healthcare disparities and other challenges make these patients highly vulnerable to increase healthcare costs and reduce outcomes. So this is where the medical home comes in, because the core principle of the medical home tried to address all of these issues. It's team-based care, it's patient-centered, patient-oriented, and takes care of the whole patient. It's coordinated care across the entire healthcare system. The patient does not have to necessarily switch providers or has to switch healthcare systems despite a chronic inflammatory disease. And it uses alternative methods of communication, for instance, telemedicine. I'm going to talk about that at the end of this presentation. It's a system-based approach to quality and safety. The secret sauce of the medical home, in our experience, is twofold. First, you have to understand the interactions between biological and environmental factors in our patients, which we call the mind-body illness interface. And that's, in fact, something that when I started, completely underappreciated in our patients with chronic diseases, where I was purely focused on, which biologic to give, what is the evidence, what's the response rate, and so on and so on. But the second big component is the team, because this type of care requires a very high level of coordination and a very high level of motivation of the healthcare team. And you see here Dr. Rieder, who established the medical home concept, but also in this picture, other providers, APPs, our psychologist, scheduler, and nurse coordinator. And everyone's happy. So would it make sense to establish a medical home in inflammatory bowel diseases? And we think it does make a lot of sense, which is why we did it. It's a chronic disease, large healthcare burden. IBD patients are often young. They have limited comorbidities, but most of the comorbidities are related to inflammatory bowel diseases. And the GI is the principal provider. We are expected to take care of vaccinations. We are expected to take care of bone health, of anemia, and a lot of other problems these patients have. This is what drove the specialty medical home for inflammatory bowel diseases. And conceptually, In this case, everything is centered around the patient. We have IBD surgeons, a gastroenterologist, nurse and nurse practitioner, a dietitian, a psychologist, and also now an inflammatory bowel disease pharmacist. The scalability of this model is very possible and depends on your center size and setup, if you want to have all components, some of them, and how many providers in each of these categories you would then hire. But I'm going to take you through a patient flow diagram of how a visit to the specialty medical home looks like in practice. You have a preclinic phase, a clinic phase, and then a post-clinic phase. And in the preclinic phase, you get referred to the specialty medical home, you meet the scheduler, and you get a patient-reported outcome questionnaire. On the clinic day itself, you see the nurse practitioner as a patient, and this nurse practitioner then determines the complexity of the patient and sets up the schedule for the day. Which of these providers that I introduced to you in the prior slide will see the patient? You can refer to a health coach. We do not have that at the Cleveland Clinic. They had this at UPMC, but this is a possibility. And then after the visit, the nurse coordinator reviews the care plan with the patient and coordinates follow-up care, for instance, also referral to services from outside of the medical home. And post-clinic, you review the patient progress, you adjust the complexity score if the patient gets better or not, and then you follow up virtually or in person with the patient in regular intervals. So interestingly, when this got started and you start the pre-visit and the patient gets a questionnaire and you ask them, what do you want to get out of this visit today? Many of you may expect, do I need surgery? Or do we need to adjust the dose of my biologic? Or I want to have less bowel movements because I have to go to the bathroom 20 times a day. But we are quite surprised about the actual needs and what the patient actually wants to get out of it. Public transportation is sucking, stressed out of my mind, pain in bones. This patient wants more energy and wants a dose of chilaxin, which probably many of us would like to have after a busy clinic day, and would like to have a massage. And these are the top 3 factors that these patients want to get out of the visit. And I think asking them is critically important, and to me was actually eye-opening because I got to go into these visits with a completely different perspective. Then the day starts with a team huddle prior to meeting patients. You go over the schedule and you determine priorities, severity scores in the patients, and so on. And then the patient arrives, gets the questionnaires, signs up for a registry, to consents for a registry. And the questionnaires we obtain are patient-reported outcomes, HBI, Harvey-Bradshaw Index, and UKI is patient-reported outcome for Crohn's and ulcerative colitis, an anxiety questionnaire, and a quality of life questionnaire. And then the visit itself happens coordinated in a hallway. Everyone comes to the patient, and this is what I meant by a very high degree of coordination is necessary, because some patients see an advanced practice provider, a gastroenterologist, a surgeon, a psychologist, a dietitian, and an IBD pharmacist in an extreme form in one visit throughout the day. So there needs a lot of coordination needed, and you see all the providers, in fact, huddled together in the hallway. And this was pre-COVID, as you can tell, because no one is wearing a mask, and we now obviously all wear masks at the Cleveland Clinic. So as an example, advanced practice provider starts the visit with the patient, collects the necessary information. The physician then discusses the plan, confirms the plan. The dietitian talks about any nutritional interventions. And then the visit ends with the behavioral health provider. This is Dr. Loop, who is an IBD specialized behavioral health provider, extremely sought after. And now, in fact, we have 3 providers that are led by him doing only inflammatory bowel disease psychologic intervention. And at the wrap-up, the care coordinator talks to the patient, re-emphasizes the plan, and establishes follow-up care. And then the after visit is also coordinated. Follow-up calls occur with either an administrator in this case, or we have brief virtual visits to follow up with the patient, see how he's doing, reaffirm the plan, but this depends on the complexity level. It doesn't happen with every patient regularly. And then once a week, there's a total care meeting where the most complex patients get discussed or any challenges that occur. So a lot of infrastructure necessary, a lot of coordination necessary, and I think a lot of buy-in necessary from the medical team. But how did we do establishing that? So what's the impact of this IBD medical home. And we separate into primary impact, emergency visits and hospitalizations, and secondary impact, disease activity, quality of life, and mental health metrics in our patients. Let's start with Crohn's disease clinical activity. And overall, the clinical activity decreased compared from before enrollment to after enrollment in the medical home. So this is a longitudinal study. This is not a randomized study. Patients get queried before they enter and then afterwards. So overall decrease, but particularly a decrease in the most severe patient with the highest quartile of severity. Comparable picture in ulcerative colitis activity, the top quartiles in severity had a decrease in ulcerative colitis activity, and overall UC activity decreased. Overall quality of life increased, but in this case, interestingly, not in the top quartiles, but rather in the two lower ones. Unclear to us yet why this is the case. And then depression improved again in the most severe patients entering the medical home, and the same is true for anxiety. So what about the primary outcome? Emergency room visits and hospitalizations, which from a healthcare cost perspective is something very tangible. And you see again depicted pre and post entering the medical home and the number of events for emergency room visits and hospitalizations. When you look at the bars overall, it becomes clear that emergency room visits declined and the number of hospitalizations declined. And this was within 1 year after entry into the medical home. And what was surprising to us is that even a short intervention, meaning 3 months, which you see in the diagonal lined bars, the 226 to 32 and the 92 to 19 hospitalizations in this case, even a short entry into the medical home led to a decline in healthcare utilization. So which patients did not improve when entering the medical home, which is obviously from a quality perspective an important information. So you may need to target these patients separately or with other techniques that we don't yet have established in our care system. And independent predictors of continuously high healthcare utilizations were steroids at baseline, opioids at enrollment, so opioid dependency, and then a low quality of life at inclusion. And these patients may in fact need a different kind of care approach which would need to be explored then for us in the future. And in summary depicted the medical home, how this looks like. The patient is in the center, and you have all the services scheduled actually physically around the patient, because the patient doesn't leave her or his room. We all come to the patient. In our case now at the Cleveland Clinic, the colorectal surgeon is also underneath the roof, but there are other subspecialties outside of the medical home which we consider outside referrals, such as, for instance, a pain specialist. And what we are aiming for is the triple aim, which is improve the individual experience, and that actually occurred. The patient experience scores improved, improve the health of populations, and we are starting to accumulate data that this target is likely being met, and then reduce the per capita costs of care. The challenges are the payment models. This works best if you have a single payer system. So if you have a healthcare system with your own health insurance, this works very well because you can make a strong value proposition to the system. It becomes more challenging if you have a multiple payer system. It's still possible, but it becomes more challenging. Another challenge is team burnout. It requires a very high degree of coordination, and then longitudinal care, a coordination with the medical neighborhood, and I'm going to introduce this concept to you in a minute. So what does this mean if you establish a medical home in terms of the type of care? So it means to move from volume to value. So the traditional IBD center, and this is how we used to practice just a few years ago, you collaborate with the hospital and the medical center. You build the center around the healthcare team. The GI is a consultant, and we only focus on IBD. We don't focus on vaccinations, on psychosocial health, nutrition, and all the other services we are now providing. It's RVU based, so the volume is a proposition for payment, and the institutional support mainly comes, in our case, from downstream revenue, surgery, pathology, radiology, and infusion costs. But the medical home chooses a different approach. In this case, it's actually a collaboration with the payer. The patient is at the center of the model, and we are the principal provider for the patient. We provide the vaccinations. We make sure bone health is taken care of. We make sure the patient has the right surgeon, and is population-based. In this case, GI works with an interdisciplinary team to care for the whole person that has inflammatory bowel disease, and it's value-based, focus on quality, preventative medicine, telemedicine, and point-of-contact mental health care. So the ingredients, and I mentioned that earlier, I think the specialist must practice smart medicine. The resources are obviously still limited. You need to address unmet needs leading to high utilization. I introduced data to you about psychosocial factors, pain control being a driver of high healthcare utilization. You need a physician champion, and you need team buy-in to do that. And you need to establish long-term collaborations with payers and healthcare systems. But the effects of IBD care and of care of patients with chronic inflammatory diseases drastically changed a few years ago with COVID-19 pandemic. There's disruptive technology that has accelerated through the pandemic, particularly telehealth. Most IBD patient care occurs in the community and not in specialty centers like ours. And IBD care is evolving into new models of care, and I introduced to you the medical home. So how does all of this fit together, and how can we introduce telehealth and the iPhone as your new primary care physician into a modern care paradigm, also serving the community? And to show you how dramatic this change was, I pulled for you the number of in-person visits, which you see here in brown, and the number of virtual visits, which you see here in green, in the Cleveland Clinic gastroenterology unit. And I marked a date for you here, mid-March 2020, which is when the lockdown started in Ohio. You see almost overnight a change from 95% in-person to 95% virtual in the way we see our gastroenterology patients. At the moment, at the Cleveland Clinic, it's about 50-50. So this, together with the fact that most patients are seen in the community, you can combine the medical home with disruptive technology to create what we call the inflammatory bowel disease neighborhood. We think this is a future care model in inflammatory bowel diseases and other chronic inflammatory diseases, to do GI specialty population-based care. And you are here today in Ohio at the Cleveland Clinic, and you can connect with patients all across Ohio. But the long-term plan here is to connect and scale, because system-wise, and you will see that in a minute, you can do that all across the United States, in fact. An example for how this looks like is your double-booked patient at 2 p.m. in your office, a 45-year-old female, single mother, 2 teenagers, with Crohn's disease, is still smoking, has active disease, abdominal pain, high stress, is depressed, doesn't sleep well, and is losing weight, is overall overwhelmed with her life, which is not surprising given the current situation. So what are your options in this case? You try to manage her yourself and work with your primary care provider and other local resources to help. You transfer care and refer this patient to an IBD center. You ask for a second opinion and then have her come back to you. Or you enter the patient to a medical neighborhood, refer her to a medical home, and then manage her locally with the key components of the medical home. And what could this look like? And I think, in fact, most of us would choose option 1, 2, or 3, and because medical neighborhood concepts are just emerging, but we are trying to establish as a 4th option for community providers to allow their chronic inflammatory disease patients to have an additional layer of care. And in this case, it starts with the primary GI, and you refer the patient either in person or telemedicine. For the first visit, we prefer in-person visits. We think it's a bit more effective, but they enter the medical home, and after that go back to their primary GI or primary advanced practice provider, but still use virtually or in person, but likely virtually, the medical home services we provide, the dietitian, the psychologist, the IBD pharmacist, and so on. And on a first visit for the medical neighborhood, it is a very intense experience for the patients. They see the IBDologist, the colorectal surgeon, the nurse practitioner for a brief introduction, because the nurse practitioner then will be key for follow-up visits in the medical home. They see the dietitian, psychologist for stress management, setting a plan for cognitive behavioral therapy. They see the IBD pharmacist to educate about medications and healthcare maintenance. And then they enter our registry. They meet the research team. But then afterwards, they stay connected to us from the distance with keeping their local GI provider. And in this case, Our Lady then schedules telemedicine visits with members of the medical home. She sees her primary GI advanced practice provider locally on an as-needed basis. So they have a combination of the services that we provide tailored to inflammatory bowel disease patients without leaving their actual environment, and we then provide a remote support structure after initial, hopefully in-person visit. So the conclusion about the IBD specialty medical home: new models of care, such as the medical homes, are emerging and improve population health, improve patient experience, and reduce cost of care. From all the data we have to date, we still need better quality data, particularly, ideally, randomizing patients to medical home care versus not, or more advanced ways to detect that, which is not trivial, but this is something we are working on. Most IBD care is in the community, so creating these models only locally is not practical. Disruptive technology to deliver care has arrived, and it has arrived, I'm sure, in all of your practices. So medical neighborhoods, in our opinion, are the future. So a hybrid model of care by medical home, remote to the patient, but preserving the relationship with the local GI care team. With this, I would like to thank you very much, and thank you for having me. We're looking forward to questions.
Good afternoon, and thank you for inviting us today. We feel privileged to be here and happy to share our experiences as dermatology partners.
We've been a team for 12, 14 years?
15 years.
15 years. See, time flies when you're having fun.
It's like an anniversary date. He forgot.
It's hopeless. We're absolutely hopeless. So really, you know, the way that probably one of the most important things about a team is, you know, that people get along. And when I met Margaret 15 years ago today, I don't know when it was, but
yeah.
Okay, she was like, "Hey, I really want to, you know, learn some more and do dermatology nursing. I'm a nurse practitioner. I want to do this." I said, "Okay, good. Let's go. Let's do it." So we sat down together in clinic and we saw patients together. And after she got over her concerns about, gee, I don't know what I'm doing, I said, fine, present patients to me. And then, you know, we kind of just developed the model together. And she was already a nurse practitioner, but she had been, maybe you should say what you had been doing rather than I say what you had been doing.
Okay, so we'll go to the next. So when I met Neil, I had spent 5 years in primary care doing family practice, which was actually made it a great teamwork because of my family practice, holistic kind of background. It worked well together. And so when we began to collaborate for the first 7 years, we spent a lot of time together, especially the first 2, pretty much solid. Then after about 2 years, I would go to some different sites, but still for about 7 years, we've always shared the same office in some capacity. The last 7, though, it's different, and we'll share that with you. But so we've had a collaboration and a partnership for 15 years, and we share many clinical patients together, both in the office and out of office, and it works a couple different ways. Right now, we never have an in-office together. I go to the Erie, PA line, I go to Southern Ohio, and I'm based out of Fairlawn, and Neil is other places. However, we're never far apart. There's a phone call for no matter what happens in the office or out of office times, which both of us prefer to take call for our own patients, given our specialty. But I want to go back, first of all, to the basis for professional collaboration, and that is, first of all, I must meet the standards for Ohio Board of Nursing, which requires that we do a chart review. And many times it's with Neil, or it'll be with the chair or one of the other physicians. So we still must meet the regulations besides what our practice prefers. So that's on top. And then beyond clinical care, this started out as 2 years as a didactic program. So I attended every didactic session with our medical dermatologist for 2 years. We did grand rounds. I still do grand rounds twice a month. I'm very active in helping to recruit for clinical trials, and we serve as an off-site center, which is amazing. I am an assistant professor in the School of Medicine and the School of Nursing, and I do a lot of continuing education, not just for nurse practitioners, but for PAs and physicians. So part of what brings us together is not only our clinical care, but our passion for research and education.
And in order to have a successful collaboration, it's all about, can you get along? And I think maybe you're already, even though you're far enough out there, maybe you can see it looks like we get along pretty well. We like each other. We're good friends in addition, and that's you can't like make that stuff up. That's gotta come. We didn't start out as good friends, but when we met, I think there was just like, hey, she's okay, and hopefully she said the same about me. I don't know.
So there are responsibilities, right?
Absolutely.
So besides education and training, we also have a scope of practice. And a scope of practice changes. When I was in my first 2 years, it changed very much. And sitting side by side, my scope of practice is still as a nurse practitioner, and I introduced myself as a nurse practitioner, and Dr. Korman being the dermatologist. We still have different scopes of practice, different background, different perspectives, and that's important. And examples of patients that we see are a great variety.
Totally. So we certainly we basically take care of the gamut of anything immune-mediated inflammatory skin disease, right? So Margaret and I are medical dermatologists. I just called you a dermatologist. I hope that's not too inflammatory in this room, but you are a dermatologist in my book, okay? You're not a nurse practitioner who does dermatology. You're a dermatologist in my book. And so psoriasis, lupus, pyoderma gangrenosum, vasculitis, and use of the latest drugs, the biologics, and all of these conditions is where it's at. And certainly over the years, it's become, in the beginning, I was teaching Margaret a lot. Certainly, I've learned a lot from her in the beginning about nursing, and I watched her. She's a great model, watching how she takes care of patients and how she works with them, and I certainly think that over the years I've gotten better at that in large part because of what I've learned from watching Margaret. And in more recent years, the answer is I call Margaret up and I say, what the hell do I do with this patient? And she said, what about this? Oh, that's a great idea. I didn't thought of that. So it's a two-way street, okay? That's, again, the definition of a successful collaboration, is that both of you can gain from it. It's not just like, oh, well, I'm the doctor, and you're a doctor too, actually, but thank God you don't call yourself one to patients, because I'm sure they're already confused enough. And if you said, well, I have a doctorate in nursing practice, that will just go miles over their heads.
So what kind of patients do we see? So Neil already mentioned one of the things that we do is we love blistering diseases, immune-mediated diseases. We don't do anything cosmetic, and you're lucky if you get us to cut anything. So that's what we like to do. But the reason why we do it, again, is my background is helpful, his scientific background, and that's what we study. We study all of these biologics. We use them in clinic. But no matter what we do, our goal is, one, to provide access to care. So did I want to leave Neil and go to Southeast Ohio? No. The way our practice evolved was meeting the needs of the community. And that's what we did as a department. And so I can provide access to care. And he's a phone call away. Also patient education, that is, and I appreciate what you said, Dr. Fernandez, and the nurse-physician team is key. And that's what we are. We're a nurse-physician team. But we also collaborate with other specialists. I would not be here right now understanding the autoimmune diseases of skin and rheum if it weren't for Dr. Korman and Dr. Brooks. I mean, they taught me so much for 10 years. And we go back and forth. So it's not just a collaboration with us. We've developed a comfort on knowledge, and we know where one ends and the other has to just hear me out and do that. And everybody's not going to start off on this level. And maybe it's not a level you desire. But finding out and what you want to do, your specialty, that's a great way. And so we have an example of a case of a patient who was pyoderma gangrenosum who was seen on main campus, right? And Neil saw her, initiated treatment, but she lives in Akron. So I began to see her. And it was not. It's one of those patients who are just medical comorbidity on top of the other. And every biologic and immunosuppressant ran out with this pyoderma gangrenosum. And then finally, she switched insurance. So again, here's the fortunate part. We come together, we talk. Can we get Dr. Fernandez to see this patient? Fortunately, yes. So it's not just collaboration between us. It's with our colleagues, our specialists, and our colleagues across town.
And, you know, Margaret, you talk about rheumatology, collaboration with rheumatology, but other specialties, as you alluded to before, GI and infectious disease. And you need to develop these relationships, and over the years, we have developed them. And Margaret and I have a coterie of, I don't know, 5, 7, 10 people that we're essentially on a first-name basis with, like, hey, here's what's going on, I need your help, can you get this person in, and vice versa. So that kind of collaboration between us, we've worked hard to stretch it out to collaboration with other physicians. I have always felt very strongly how important it is to get on the phone and talk to people. You guys were talking about getting on the phone with patients and, you know, telling them what's going on, but it's the same thing. If you have a patient who's got one dermatologic disease and another comorbid GI disease, infectious disease, whatever it is, you have to decide like which one's more important now, right? And the colleagues that we have worked with over the years, the large majority of them are okay to say, you know, you're right, I think the skin is more important here. We need to back off on this and do that. And I alluded to that earlier when I presented on blistering diseases and said, you know, well, maybe we shouldn't rush to get Rituxan on board because of the risk that we're putting patients at risk with autoimmune blistering diseases right now at the height. I heard we read just yesterday or today, we now went into the red zone in Cuyahoga County for COVID. So, you know, it's still there. And you gotta, I mean, I have talked for years. I haven't ever done it. Maybe now that I'm saying it out loud in front of an audience, maybe I'll do it. But I want to write an editorial whose title is Pick Up the Damn Phone. And I mean it from physician to physician, because there's a fair number of people that you need to talk to them, and you leave a message, and you email them, and da-da-da, and they're like, what's a phone? You know, you said that patients don't answer the phone. Doctors also don't answer their phones.
And nurse practitioners.
Yeah, okay, sorry, you're right. I'm
But we do, and we're very, very grateful. So in summary, we're about the right fit.
And that's hard to gauge in advance. But what I would encourage you to do is be open-minded. I was open-minded, and I was rewarded. And I feel like I'm continuing to be rewarded. So I think, yep. I know, this is yep. We're up here saying we're a good model. Nah, we're up here saying we're a great model.
And a happy model.
Yes.
So what we encourage you to do, look for the right fit. It has to be about personality. It has to be about work ethic. It has to be about patient quality outcomes that are your ideal, and that's important. And then educational preparation. I was family practice certified initially. I never would have been able to have this opportunity to do what I do now had I not had, this is an exceptional fellowship that we have. So it would never be so had it not been for Dr. Cooper and Dr. Korman teaching me for 2 years. But we also have to do surveillance. There are many times when I have to say, I don't know, and I call Neil and I go through it. He said, well, actually, I think you did know. But there are many times we bounce things off each other and I didn't think of it. But you also have to do chart surveillance. You do have to do chart audits in the state of Ohio. Plus, when we get feedback from our colleagues, we are better. That is true. And then there's, of course, demonstration and documentation. Documentation is everything. And so I can pick up a chart and I can send it to Neil, and I know everything is in there. And that's important, or we can't work remotely. That's key. And so that is it. But ultimately, our quality care and patient outcomes are really our priority.
And the answer is we're getting those. So thank you very much.
Thank you.
Thanks, Tony. Thanks for having us. So rheumatology is a little bit different than dermatology. For one thing, we have a huge national workforce shortage. My understanding is that in general in dermatology, there is not such a shortage, but in medical dermatology, there might be. It might be a little harder to find people to see those blistering diseases, in North Dakota, which is sort of similar to how we are in rheumatology. So there's this huge shortage, which has really driven more use of NPs and PAs over the last several years because there's just nobody else to see these patients. I have a colleague in Alaska who's a PA in rheumatology, adult rheumatology, and if you have JIA in Alaska, there's one rheumatologist who will see you, but if anything more complicated than that and you're under 18, you have to fly to Seattle to get your care. So that's why it's, these relationships and these collaborations are so important just to get the care out to the patients who need it the most. So I'm going to back up a little bit, just in case anybody doesn't know. What is an APP? Nurse practitioners have to have a master's degree. They may have a PhD or a DNP like Margaret and I do. Physician assistants must have a master's degree. They may also have a PhD. And in rheumatology, we include our clinical pharmacists in the APP scope. And as you all know, clinical pharmacists have to have their PharmD. So we have a whole team of APPs ready and willing to help our rheumatology patients. In rheumatology, in 2019, about 50% of practices employed APPs. It's gone way up since then. I don't have actual numbers for you, though. Sorry, there hasn't been a repeat of this particular survey done. But back in 2019, it was about 50% private practice or not private practice. Academic medical centers used APPs in their practice. So what is the general scope of practice for different APPs? For an NP, depending on where you live, you may need a collaborative agreement with a physician. It varies by state, and we're going to have another slide out in a minute, but some states you can be fully independent. You do not need a collaborative agreement. If you wanted to, you could just hang your shingle out and say, I'm Betsy Kirchner, and I'm here to see rheumatology patients. Some states have reduced practice, some have restricted practice. PAs at this point are still always in collaboration with a physician, and in the actual legal lingo, nurse practitioners have a collaborative agreement and physician assistants have a supervisory agreement with physicians. We all know that depending on your practice, it's typically a very collaborative two-way street, as Margaret and Neil were saying, but legally that is how it stands. And clinical pharmacist, the scope typically is governed by your practice setting. So whether you're inpatient, outpatient, rural, urban, you could have a huge difference in your scope of practice. So this is what I was talking about before. This is by states in the United States. Green means full practice authority, and Kansas and New York look a little weird up there because they just passed their full practice authority laws, and they haven't updated the map yet, so I just had to sort of stick those in there. But they're green now. Ohio is a yellow state, reduced practice, so we do have to have that collaborative agreement. And then the red states have a restricted practice. Now I'll say, I have a friend who's an NP in Michigan, which is a red state, and she owns her own practice, her own rheumatology practice, and that is because nobody in East Lansing, Michigan would see patients with Medicare or the VA overflow in the rheumatology world. And so she got a special dispensation from the state to open her own practice to see this underserved population. So it can be done, but you have to work around the legal aspects of it depending on which state you're in. So specifically at Cleveland Clinic, what do we do? What do I do as a rheumatology NP? I see new patients. I have 4 new patient slots a day on my schedule. Some of them will end up being in a shared cohort. Some of them will never see a physician. There's too much of a shortage. So if you've got gout and it's stable and there aren't any huge comorbidities and it's, everything's going great, there's no reason for you to go see Dr. Hajj-Ali to manage your gout, when she needs to be seeing complex vasculitis patients. We also see follow-up patients. We see our own follow-up patients. We also see everybody else's follow-up patients, and that is in red for a reason. So if you are thinking of having, introducing APPs into your practice, overall in terms of satisfaction surveys, having one APP to 20 physicians is not going to work out. There's 20 different ways of treating every single disease out there, and so having a smaller pod sort of situation tends to work better. The biggest rheumatology private practice in the Southwest is in Phoenix, and they have 3 APPs to each physician. So it's flipped. So, and they're very successful. We order labs, imaging. We order any testing that needs to be done. We order meds. The NP scope of practice in Ohio, the only thing we can't prescribe is medications that are only for abortion. So yes, we can prescribe methotrexate, but just medications that are only approved for abortion, we cannot prescribe according to the state of Ohio. We can't prescribe Schedule I, neither can anybody else, and we can't prescribe medical marijuana. But there's also the CCF formulary, which is a little bit more restrictive. So at Cleveland Clinic, I cannot prescribe cyclophosphamide, and there's a couple other oncology drugs that NPs are not permitted to prescribe. We do large joint injections, we admit patients, we refer patients, and we bill independently at the Cleveland Clinic. You can bill incident 2 when you're in a collaborative agreement, which makes you more money, but it also makes you invisible, and it works out better for the clinic. They decided years ago that NPs and PAs would bill independently. Okay, Rula.
All right, so I can go there. Okay. So as you heard, Betsy, there's a huge shortage in rheumatology, and even if there was not a shortage, so actually you have to have APP in your team because it works differently. It's like, looking at this big elephant, everybody looking at it in a different perspective. When I see a patient and I share a patient with Betsy, she finds out things that I have not looked at. It's having 2 people look at the same patient from different perspectives with the common goal is to get the patient better. So really it's a very important to really have APPs in your team. So what APPs don't do at the Cleveland Clinic is hospital services. That's in rheumatology. We actually don't have our hospital service as a primary team. We are consultant in Cleveland Clinic. So even the rheumatologists don't have hospital service, but they are consultant there. And they don't take calls, and they don't do small joint injections. So how do we work? There are different ways how we, the APPs in physician work, but how do we work at the Cleveland Clinic is we do shared cohort, and what does that mean? So I see a new patient, and from my experience, when I see this patient, let's say I want to start biologic on a patient, or even methotrexate, and as Tony have mentioned, there's so much anxiety and so much that the patient can retain in this first visit, and you're trying to do your best to educate this patient. At the end of the day, the research says they only retain about 25% at most. So you do all that, they go home, they have 100 questions, right? So your APP and your team is really very important in incorporating all these messages. So what I do, let's say I'm starting a new medication on a patient, and I introduce my team. So we are very lucky to have our APP on the team. We are very lucky to have our pharmacist on the team. But this confidence that the patient needs from you, that they're not going to see you. You have to tell them that. They're not going to see the physician all the time. We work here as a team. We all communicate together. I found this really important for the patient and for me to help me out with introducing the patient for the rest of the team, even though they don't see them when the first visit. However, it's important to know and the expectation. And I found this very good. And Betsy also, if she sees a new patient herself and she wants to refer it to us, she introduced that. Anyway, we work as a team here. We all here to serve your needs, and you're gonna hear from all of us. And this is what a shared cohort look like. I see a new patient, I start a new medication. I would like them to be seen in a month I don't have, with all the needs in rheumatology, I don't have the time to see them in a month. The APP team, Betsy will see them. You're going to hear from Chrissy, our clinical pharmacist, which has been also great addition in our team, who can see the patient, who can counsel the patient about medication, can educate the patient about injections, and this is what is the shared cohort look like. And the patient like it. They have many people they can reach out for any question. If I'm not answering, Betsy will answer. If Betsy is out, I will answer. Usually Betsy answers better than me. But they really like it. I have not had any complaint from a patient that they don't want to see an APP, unless, it would be very rarely, it would be the same thing that they probably don't want to see me too. So I haven't heard any complaint. And it does help both of us. It helps access. It helps patient education. It does help giving multiple opinion on the same patient. I've missed so much that Betsy picked up. Things that I don't know about patient assistant, Betsy will just say, oh yeah, we could do that. And she's magically can do it all the time. So it's really a great addition for the patient. And nowadays, the healthcare system, you cannot be solo. There is no way. And you need as much help as you could in your practice. And pharmacists, nurse practitioner, physician assistant, nurses, they're all around you, and they're of great help. And we should really work as a team all together. What's the downside of shared cohorts? I'm sure there is multiple. One thing that Betsy put in there is the dumping syndrome, which is can lead to dissatisfaction and burnout. Is that like if somebody just like I saw the patient and then just Betsy seeing them over time, and there are demands that she or I cannot do, but they're all only seeing her, and I don't think that will go well for communication between us and with the patient. And the most important is actually communication in the shared cohort. Like if I do something, change something on the patient, I'm sending that chart and the message to Betsy so that she knows. And if Betsy doing something, she send me the chart and the messages to me, so we all know and understand what's going on in the patient. The last thing you wanna know is that when you talk to a patient and say, oh, I wasn't aware of that, and that the confidence just dropped down, and patient would not really follow very well. So this is the main thing. We have lost APPs that they felt their burnout. At one time, we didn't have so many APPs. Luckily, we have hired so many, and we are looking forward to work with all of them, and they've been a great, great pleasure to work with all of them. Betsy has taught me so much over the years. We've been together for 22 years. Mm-hmm. I started at the clinic at the same time that she started at the clinic. I started my fellowship and she started, and we kind of learned together how to do things, and we just, a great team. Wherever I know, I shared with her. Wherever she knows, she shared with me. If I do something, wrong, she just tell me, and just this is not right.
Never happened. Never happened.
Patients like that. They do really like to have more than one person in the team, and they can get to her schedule, they can get to my schedule. We have a patient who is able to get to both our schedule every month. And, there's, I think the most important for the patient is that they feel that there's somebody is caring for them and is not just lost in this huge system that they cannot get in, they cannot have their questions answered, etc. But if you have more than one person, it's really important. Also having pharmacists on the team has been a great addition to our team, and you're going to hear from Chrissy in a little bit, but this has been an enormous help in our practice as well. We
This is
have
our team.
32 staff physicians, 27% are FTE, 14 are actually full-time. We have 12 nurse practitioner or physician assistant, all full-time except one. We have Chrissy is our pharmacist, and we work in 11 regional sites in addition to the main campus. So let me just add one thing. So Betsy moved her clinical practice to the satellite. And at first I said, oh, this is not going to work with my patient. Actually, they like it because they could see her somewhere probably closer. And we have other APPs in different satellite that I see them in the main campus, but they're, anywhere else is close to their homes, and they love it.
Free parking.
Yeah, and a free parking. And also doing the virtual visits, it's not, things have changed over the pandemic. This is one of the things that it has affected actually positively. Our healthcare is having more virtual visits. This has not been an issue to be in the same location. But I think at first, as Margaret have said, also just having this connection, and as Betsy said, you really have to know, the practice of the physician that you're working with to have the same goals. And also, I was talking to the other APPs, and I said, the more you work with so many other people, you're bringing different perspective to your patients as well. So at first, what we have is when we hire new APPs, Betsy does a great job in training them, and we have them train with so many physicians in our department. So they learn different styles. Everybody has different things to add to the same patient, and they learn different style that they bring all together to the patient. But having, it works much better if you have one or two physicians in your team, and Betsy can add to that as well, because it makes it easier. And Betsy and I have our cell phones. She can text me, call me anytime, and communication is the most important, as we all know.
Okay, I just added this on at the end real quick. Everyone wants to know this, so I just figured I'd put it out there. The big white box is a national survey, a salary survey. It's not specially specific. It's not derm, it's not rheum, it's not family practice. It's just average everything together. And that's sort of what you're looking at in terms of pay differentials. The box on the right is a rheumatology salary guide from ACR, American College of Rheumatology, and that is also a national average. So if you're thinking of hiring an NP or PA, that is not what we make in Cleveland. That's, I think, what they make in maybe a very small town in Kansas or something. But just so you have the idea of you can get two APPs for the price of one physician, is the big picture. And if you're trying to expand your practice, if you're trying to see more patients, if you're overwhelmed with the number of patients, it's you can add on a couple APPs, really get it going, and then hire on your next physician, then a couple APPs, and that model seems to work really well in the private practice world. So that is all we had for today, and thanks so much for your attention.
All right, good afternoon, everybody. My name's Sean. Glad to be here to discuss the role of the specialty pharmacist in the role of optimizing patient care for our psoriatic patients. The main objectives for my part of the presentation is to discuss some of the roles and responsibilities of the ambulatory clinical pharmacist and especially pharmacists in the care of the psoriatic patients, review the definition of specialty pharmacy, and evaluate some of the common challenges regarding patient access to specialty medications. There's lots of them. Identify potential benefits of multidisciplinary care with clinical pharmacists, and identify challenges to incorporating a clinical pharmacist into an ambulatory clinic. So my portion is mainly going to be talking about what a specialty pharmacy is and kind of describing the impact that specialty pharmacists can provide for patients. Generally speaking, specialty pharmacies are distinct and different from traditional pickup retail pharmacies in that we help to coordinate many aspects of patient care and disease states. If we think about what a specialty medication is, usually it's very high dollar, high touch, could be limited distribution, where only certain pharmacies across the country do have access to dispense. Essentially, the specialty pharmacies are designed to efficiently deliver medications with special handling. A lot of these biologics are refrigerated medications, storage and distribution requirements. And specialty pharmacy staff, they are trained and designed to improve clinical and economic outcomes for patients with these complex and rare conditions. There are a wide variety of disease states that a specialty pharmacy can service. This is not an all-encompassing list. Cancer is a major one. I, of course, highlighted dermatology and rheumatology. Other examples of certain disease states would be growth hormone deficiency, HIV, hepatitis C, hyperlipidemia, other cardiac abnormalities, hypertrophic cardiomyopathy, inflammatory bowel disease, Crohn's, UC, multiple sclerosis, movement disorders, Parkinson's disease, solid organ transplant. The list can go really on and on. So, and then wanted to touch briefly on this graph relation. Come as a surprise, but it's essentially showing that more than or almost a third of the biologic prescriptions for inflammatory conditions were in fact obviously prescribed by someone in the dermatology or the rheumatology space. There's a wide variety of duties and tasks and responsibilities of a specialty pharmacist. Direct patient care to make sure it's the right medication, the right dose, side effect management, side effect counseling, etc. Lab and adherence monitoring. As Dr. Fernandez mentioned, adherence, of course, is of the utmost importance. So, for example, our technicians reach out to the patient every month to set up their refill shipments. How many doses do you have on hand? Do you have trouble remembering to take your medications? Would you like to speak with a pharmacist? All that is documented in the electronic medical record as well. Order product verification. These are very expensive medications, usually several $1,000s a month a dose. So we want to make sure that we are processing it through the insurance in a proper fashion. So making sure that the quantity day supply is appropriate, not to commit fraud or anything along those lines. You're especially drug therapy expert, and education is a big part of it as well. So storage and handling of medications, again, lab monitoring, making sure there's no contraindications to a specific biologic or therapy as well. I pulled a couple studies. This one was looking at the pharmacist's impact on outcomes for dermatologic patients. The main objective for this study was to determine patient and participating pharmacist views of clinical interventions for dermatologic patients with psoriasis. These patients were, the main intervention was telephone interviews. So the patients were recruited when they either presented to a pharmacy or via a letter of invitation based off pharmacy records. So essentially what happened, there was one face-to-face consultation and follow-up appointment after approximately 6 weeks. 38 patients, and they conducted telephone interviews, and they essentially surveyed the patients and explored pharmacist perceptions on the value of the intervention. So essentially the results showed that about 3/4 joined the study to learn more about their condition, and a little more than half reported increasing their knowledge of their condition. Most patients believe psoriasis improved as a result of advice received during this intervention, and the pharmacist's perception was that they improved their own knowledge of psoriasis. There are also lots of responsibilities, especially pharmacy staff. Collaboration with other healthcare providers and interdisciplinary teams is key. Documentation and electronic medical record, that's very important as well to make sure that the providers and other healthcare professionals are updated in terms of patient status and medication order status. Proactive coordination of refills. A lot of pharmacies proactively reach out to the patients to set up the refill shipments. These, of course, are very expensive medications, the biologics, so you want to make sure that we don't automatically ship out or anything like that. Make sure that patients are in need of a refill, confirm address, those little nuanced things that we may not think about, but making sure that this expensive drug gets to the correct patient at the correct point in time. Specialty pharmacies, there are a wide variety of accreditations. I highlighted URAC here. URAC is the main gold standard for accreditation for specialty pharmacies. URAC is a Utilization Review Accreditation Commission. It's an independent accrediting body, promotes quality through education and measurements. Essentially, with URAC accreditation, specialty pharmacies have to meet a lot of different criteria. So, for example, did your pharmacist, check for a TB test before starting a biologic? Was that documented? Did they document adherence? They document, how much the patient was, how many doses the patient missed. There's also, for example, phone metrics. So did the pharmacy staff answer the phone in 30 seconds or less? So there are a whole, wide slew of criteria that the accrediting bodies do look at. The benefits of accreditation include, but not limited to, ability to access limited distribution drugs. So limited distribution drugs are those medications that not every pharmacy has access to dispense to. So with our accreditation, we can go to a drug manufacturer and say, we have this accreditation, please consider us for being able to order your medication and being able to dispense that for our patients. It also serves as external validation of pharmacy practice and outcomes, and also kind of helps to serve as a guideline on how best to set up and maintain pharmacy practice. There are a lot of different access challenges to specialty medications, insurance and cost being, again, not all-encompassing, but the main ones. So in terms of prior authorization, formularies, and step therapy, our docs can attest. I send them, all these love letters about, prior authorizations being denied, XYZ drug denied, you gotta try 8 other drugs first. So that would be an example of a formulary where there's a preferred biologic over another. Step therapy, an example of that in the dermatology space would be, patient has to try non-biologic DMARD before a biologic is covered, or they got to try, phototherapy or something before a biologic is covered. So insurance, does play, unfortunately, a big role in terms of preventing timely access and administration of a biologic medication. There are options to overcome that with the insurances. There are options for appealing. Certainly, the drug manufacturers may be able to assist as well. So it's just knowing how to navigate and navigating those issues and knowing how to resolve them. Medication costs, again, these specialty biologic medications, several thousand a month, several $1,000s a dose. The specialty pharmacies should be well versed in terms of what options are available for financial assistance, whether it's a commercial copay card, whether it's patient assistance or free drug directly from the manufacturer for those patients who are uninsured or who have government insurance, for example, and the copays are extremely high. The second study that I pulled was estimating the value of pharmacist interventions in a specialty pharmacy setting. Essentially, the main goal of the study was to analyze interventions in a specialty pharmacy and provide the estimate of economic value of these interventions. It was a retrospective study. The interventions that were completed were documented and categorized using a coding system where all prevented outcomes were predicted to occur, and about half of the total cost of prevented outcomes would be incurred. So essentially, about 1% of the total amount of interventions that were documented were pharmacists' interventions. The estimated value of interventions was enormous. It was 2 to 4.6 million, but the main conclusion was that most of the pharmacists' impacts were predicted to have prevented an unnecessary hospitalization, which can lead to profound clinical and economic value. I have a couple polling questions, not meant to trick anybody. So which of the following is false regarding specialty pharmacies? Would it be A, are they distinct from traditional pharmacies in coordinating patient care / disease management? B, designed to efficiently deliver medications with special handling and storage requirements? C, designed to improve clinical outcomes and economic outcomes for patients with complex and rare conditions? Or D, specialty pharmacies typically dispense low-cost and low-touch medications? I heard D. Yeah, that's your question. Yeah. Last one, which of the following is a common barrier to patient access to specialty medications? A, medication non-formulary on an insurance plan. B, pharmacist intervention. C, lack of URAC accreditation. Or D, lack of nearby specialty pharmacy. I heard an A. I think I did. Yes, correct. Yes. Although a case could be made for maybe the other three, but essentially nearby specialty pharmacies are usually mail order. Lack of URAC accreditation could have a minor impact, but the best answer would be medication would be anything insurance related. So in summary, specialty pharmacists and pharmacies are equipped to manage patient care to improve clinical outcomes, and many challenges and yet solutions exist for improving patient access to these high-touch, high-dollar medications.
All right. Hello, everyone. My name is Duly. I am the rheumatology clinical pharmacist in our rheumatology clinic on main campus. So I'm going to start out with a poll here. Based on U.S. claims database, what percentage of adults with psoriatic arthritis who are newly initiated on a biologic therapy will discontinue it within 12 months? Do we think 13%, 34%, 56%, or 85%? So the answer to that is actually C. So a little over half of patients that are newly initiated on a biologic will discontinue it within 12 months. So that's not entirely taking into account the reason for discontinuing. There could be a good reason, but adherence could also play a large role in that. So my role in the rheumatology clinic, as I said, I am embedded within the clinic itself. So Sean and his team work at our specialty pharmacy. We're in close communication, but I'm right there across the hall from the doctors, so they can talk to me at any time. So a goal is to focus on optimizing medication therapy, both through direct and indirect patient care. So I'll get into a little bit more, but I do see patients mostly virtually for visits, but also indirect care such as answering medication questions, helping navigate issues with insurance, and so forth. So for patients, this helps to increase their access to care. So as Betsy and Dr. Hajj-Ali talked about, another touch point for patients, and also another person to see for visits, especially if it's issues with medications in between their scheduled visits with providers. Also able to increase comprehensive medication management, so going through not only rheumatology medications with the patient, but answering any questions they have about other medications, assuring that there's no drug-drug interactions, so really helping to manage medications as a whole, but also focusing on those rheumatology medications. For providers, this can help decrease follow-up appointments needed with them. So I am able to provide follow-up in between visits, see them a little bit more closely and at shorter notice, That frees up the provider's schedule to be able to see more complex patients, to see new patients. And this also helps to decrease provider burnout. So providers aren't handling everything related to the patient all on their own. I'm there as a resource for any issues, questions, concerns with medications. Clinical pharmacists then can help to increase quality metrics and decrease medication costs, so help with many projects regarding quality insurance, quality improvement, whether that be decreasing Part B spending or making sure that we're meeting metrics like patients getting TB tests prior to starting a biologic. So just a couple studies that looked at pharmacists' involvement and the impact that they can make in rheumatic diseases. So one being a pharmacist-led virtual gout management clinic. This was a randomized controlled parallel trial where they looked at patients with gout who were either managed via telephone visits with a pharmacist or managed via usual care with their provider. And in this study, they saw that over a third of patients met their uric acid goal at 26 weeks of less than 6 versus 13% in those for the usual control group. So the pharmacists were able to manage the patients via telephone, have them get their levels, check in with them in 2 weeks, make dose adjustments, and really help to reach that goal at a more rapid pace. Another study, a case study looking at a biologic pharmacist clinic. So this was a weekly clinic led by pharmacists for biologic naive patients, but also stable patients who maybe required a switch in biologics or just needed monitoring. And in the time period that they measured, they had 75 patients seen, 18 of these with psoriatic arthritis, and they estimated almost 40 hours were saved for providers, and this helped with rapid biologic initiation, enhanced medication reconciliation and education, and also making sure that the requirements necessary for safety for starting a biologic were achieved. So as far as my role for chronic medication management, so I assist with disease and medication management through a collaborative practice agreement. So this varies state by state as to what pharmacists are allowed to do, but in the state of Ohio, we have pretty robust laws for pharmacists. So I have a formal relationship with physicians and APPs that authorizes me to help manage patients' drug therapy for specified diagnoses. So I have a list of medications that I'm able to make dose adjustments to, even potentially start medications, and then also order and evaluate lab tests associated with that specific drug therapy. So I see patients for a variety of conditions, but commonly psoriatic arthritis, rheumatoid arthritis, gout, and uveitis, I would say, are the most common that I follow for medication management. So this is an example of kind of a flowchart of what my involvement might be in co-management with a patient with psoriatic arthritis. So often a provider will conduct a visit with a new patient, and as we know, with new patients, we don't always have the answers right away as to what the diagnosis is, what medication would be best. We may need additional lab work. So after completing all of those steps, I'm able to step in and help either at that same visit or with a phone call maybe the next week to review the medication options with the patient. Go through the pros and cons, risk benefits, and really participate in that shared decision making. After the medication is prescribed, we try our best to send it over to Sean's team at Specialty Pharmacy so they can assist with insurance approval, copay assistance, patient assistance programs if needed. I love working with them because we have their notes in the chart. We can see what step they're at in the process, so it really makes co-management easier. After that, if a patient's new to a biologic or injectable therapy, I will often complete injection teaching either in person or virtually with the patient. Also, it helps having a pharmacist or nurse practitioner or nurse complete those visits to be able to answer medication questions. From there, since it may sometimes be hard to get back on the physician's schedule in a timely manner, I can help conduct follow-up visits to assess adherence, assess tolerance, safety, make sure patients are getting the required labs. I'm able to order the labs myself, so often I'll check in with a patient a month after starting, and then maybe again a few months after they see the doctor again. And that way, as I alluded to, provider follow-up can then be scheduled further out, allowing them to see new consults or follow up on more urgent patient concerns. So just talking through my clinic activities, so I discussed focused medication education appointments. So a lot of the medications we use in rheumatology and dermatology can be a little bit scary for patients, especially after they do a Google search and read about it on their own. So I'm able to set aside time to talk through the medication with patients, discuss their concerns, discuss potential side effects, but also discuss the benefits. I do a lot of self-injection teaching appointments with patients, also following up on new medication starts. One, to check in a month later to maybe see, are they tolerating it well, but also that way they're not going a full 3-4 months. They see the physician, they say, oh, I never actually got the medication. So able to intervene sooner. And then answering any medication-related questions. So if a patient sends a MyChart message about a weird side effect or something about the use of the pen or storage, they can consult me and forward that along. I also serve as a liaison between clinic providers and specialty pharmacy. So they will often reach out to specialty pharmacy themselves, but also I'm there to kind of be the middleman between the two. We message a lot back and forth on Epic, helping with appeals and patient assistance programs. So appeals are a big one that I kind of step in and able to help write a very convincing and hopefully successful appeal letter for a patient, especially in rheumatology, since we have a lot of more rare conditions where a medication might not necessarily be FDA approved. I help with education and support of our advanced practice providers, residents, fellows, pharmacy students, and really just serve as a general medication resource for clinic providers. So my door is always open to stop by and ask questions. And then finally, helping with quality improvement projects. So just to discuss some potential challenges to incorporating a pharmacist into your clinic. So in the state of Ohio, pharmacists have achieved provider status with Medicare. However, it's taking some time to catch up and really get that incorporated into clinics. So I currently don't bill for any of my services, but the time that I use with patients is able to free up time for our other APPs and doctors to see more complex patients and bill for that. It can be challenging with the alternative appointment styles. So most of my appointments are either virtual or over the telephone, mainly because I'm not completing as much of like a physical exam component, but sometimes it can be difficult to get a hold of patients virtually. As Dr. Hajj-Ali and Betsy said, we've hired a lot of new advanced practice providers lately, so clinic has been booming a lot lately, so sometimes finding the clinic space for conducting a visit can be more difficult, which is why most of my visits are virtual. And then thankfully, I have had no trouble with this, but obtaining buy-in from providers and patients, sometimes when you first start seeing a patient, they don't understand what a pharmacist is doing, being involved in their care, but then they quickly will catch on and really appreciate the assistance. And I've been lucky to have great providers at Cleveland Clinic Rheumatology that really trust me and incorporate me into the care of patients. So in summary, clinic-embedded pharmacists can partake in various clinical activities to enhance patient care and reduce provider burnout. And future opportunities lie in billing for services and being able to generate additional revenue for the clinic. And we'll save questions.
So we're going to talk to you today about psoriatic disease patient education and compliance, and how we worked as a team to try to educate patients and again, ultimately to get the best treatment outcomes for them. Here are my disclosures. None of these activities impacted the formulation or content of this presentation, and Colleen has no conflicts to disclose. We can really use the strategies that we're going to talk about today for patients with any chronic inflammatory or autoimmune disease, and certainly we did that over the 10 years we spent together, but we're going to focus on psoriasis for numerous reasons. First of all, it's a very common chronic immune-mediated disease. We're all going to see numerous psoriasis patients in our clinics. And I think there's some important things about psoriasis that really make education and teamwork important. First of all, I think now, as everyone well understands because of the outstanding lectures earlier today, we have learned a lot about the pathogenesis of psoriasis from a cellular and molecular standpoint over the past 30 years. And the detail that we now understand the pathophysiology of this disease has allowed for the development of all the targeted medications that you heard about earlier today. And these medications, also as you've heard, have outstanding efficacy and safety compared to all the medications that we've had before them. Several years ago, the medical board of the National Psoriasis Foundation published treat-to-target guidelines for patients with psoriasis. And the consensus of the medical board was that your target should be for a psoriasis patient to have no more than 1% body surface area involvement of psoriasis at the 3-month time point after starting a treatment regimen and thereafter on maintenance phase. And you can think of 1% of a patient's body surface area as roughly being the surface area of the palm with the thumb. So your goal should be for the patient to have no more than 1 palm's worth of psoriasis on their skin at the 3-month point and thereafter. Although the medical board acknowledges that, look, it's acceptable to have a little more psoriasis for that. These are aggressive targets, and I think one of the reasons why they can be so aggressive is that we are spoiled with all the outstanding medications that we have. And the reality is we should be able to reach that target in the vast majority of psoriasis patients that we see. But I think all of you see patients with psoriasis who are nowhere near these targets, and many of them have been on these medications. So why is that? Why are patients not meeting those targets? And an important reason, one reason why they're not, is because of non-adherence. Non-adherence to medication in psoriatic patients is a significant problem. And in fact, non-adherence to medication is not unique to dermatology or patients with psoriasis. It is a well-known problem in all fields of medicine. And if we look at medication-related hospital admissions in the United States, research has suggested that anywhere from 1/3 to 2/3 of all those medication-related admissions are due to poor medication adherence, and that costs the U.S. healthcare system about $100 billion. And of course, non-adherence to medications causes much more than just hospital admissions. It results in treatment failure. It results in disease progression. For systemic inflammatory diseases like psoriasis, it results in the onset of numerous comorbid diseases. And all of those end up with patients who require more healthcare visits, more healthcare attention, more healthcare dollars. So the overall cost of medication non-adherence is somewhere between $100 billion and $300 billion per year. So why is it that patients may be non-adherent to medications? Well, in a systematic review of factors that influence treatment adherence, specifically in patients who had chronic inflammatory diseases, authors concluded that, well, whether or not a patient is adherent to medicine is a multifactorial issue, and it's related to factors that can broadly be broken down into 4 categories: patient-related, treatment-related, disease-related, and physician-related. And under each of those categories, there are multiple specific factors that influence whether or not a patient is going to be adherent to a medication. And Colleen and I would argue that many, if not most, of these factors can be adequately addressed or mitigated by good nurse-physician teamwork. And we're going to share with you sort of our strategies as we walk through a patient who comes to our clinic with psoriasis. So obviously, the first thing that happens is a patient comes to you with a problem, a rash. And for me, once I feel confident after talking to the patient, doing an examination, doing any other studies that we think are necessary, but having confidence that the patient has psoriasis, the first thing I like to do is assess that patient's disease severity. The National Psoriasis Foundation has published definitions of psoriasis severity based on body surface area involvement. Less than 3% is mild, 3 to 10% is moderate, greater than 10% is severe. But I think most of you know that we need to look at more than just body surface area to assess overall disease severity. First of all, we need to look at the anatomic locations involved. If a patient has psoriasis on the face, the palms or soles, the genitalia, then obviously they can have a minimal amount of body surface area involvement, but still be considered moderate to severe disease in terms of impact. And we have to look at that impact. What are the physical symptoms that the patient has because of the psoriasis? How is the psoriasis affecting the patient from a mental health standpoint? All of those are important in assessing overall severity. And then I think it's also important to get the patient's perspective. Ask the patient, how bad do you think your psoriasis is? What would you categorize your severity? In one of the largest international survey studies of psoriasis patients ever performed, 27% of all patients stated that their psoriasis was severe. And that included more than 20% of patients who had less than 3% body surface area, so who would be qualified as mild disease if we just looked at body surface area involvement, and almost 40% who would otherwise be considered moderate disease. So clearly there can be a disconnect between how a physician assesses severity and how a patient assesses severity. So we need to include our patients. We're going to focus really today on moderate to severe psoriasis patients. Once I have assessed a patient and believe they have moderate to severe disease, the next thing I do is take a little bit of time to try to educate the patient about psoriasis. Most importantly, educating them that psoriasis is a systemic inflammatory disease. And you heard great lectures this morning from Nehal Mehta and Andy Blauvelt about that. I do mention that there's an increased risk of comorbid diseases. I don't mention all of these, but I usually will mention that increased risk of cardiovascular disease and psoriatic arthritis. The reason I spend time doing this is not only because I think it's important for a patient to be educated about what he or she has, but I think it really helps to frame why the next thing I'm going to do is talk to the patient about starting them on a systemic medication for what they may have thought was just a skin rash. I think if they understand it's a systemic disease, they immediately understand why we're talking about these medications. In talking about the medications, I do like to stress that when we look at the data, when you have moderate to severe psoriasis, the data supports a favorable benefit-risk ratio to taking these medications. And then I think it's really important to set appropriate treatment goals. You cannot assume that your patient understands that these medications do not cure their disease. They just control the inflammation and hopefully make the rash and associated symptoms go away. But if they stop the medicine, all of those symptoms are likely to come back. You have to take time to do that. Patients don't understand that just inherently. And then, of course, you want to take time to let the patient ask questions and voice their needs and concerns. So I think already this early in the encounter, you can get a sense that nurses, physicians, anyone involved in communicating with patients needs to develop reliable and good teaching skills. We're teachers. I tell my kids that all the time. They want to be a teacher. I say, well, you should go into medicine. That's all I do all day. One of the things that's really important is to not use medical terminology when you're talking to patients, and I see this sometimes. You can't tell a patient, you can't educate a patient about psoriasis and say, well, this is a Th17 mediated disease and you have increased, they're not going to understand it clearly. I mean, we laugh, but I see that sometimes. You have to figure out how to put into words that the patient can understand what the disease is and what those medications do. And research has shown that if you do not do that, if you assume that a patient understands those terms, any medical language, you're at a high risk for misunderstanding, and misunderstanding is a huge risk factor for medication non-adherence. The research has also shown that physician-patient communication is central to whether or not a patient is going to be adherent to a medication. There's less research looking at nurse-patient communication, but the little bit of research out there also supports that good communication drives good adherence. One of the most important things that you want to try to achieve is having the patient have trust in you and a physician. Physician trust has been shown to be one of the most significant predictors of treatment adherence. So when I'm ever teaching a medical student or a resident, I like to say, speak with confidence. Speak like you know the disease in detail and that you're very confident in the treatments that you're talking to the patient about. And even if a patient asks you a question and you don't know the answer to it, say, I don't know the answer to that question, but I'm going to try to look up the answer and get back to you, and say it with confidence. Having a patient trust that you know that you're doing the best for them and are making good decisions is critical to patient adherence. When it comes time to making a decision about medication, I like to use shared decision making. I'm sure most of you, if not all of you, are familiar with shared decision making. This is becoming more and more common, not only in dermatology, but in all aspects of medicine. And essentially, it entails educating the patient about the risks and benefits of the treatment options, and then facilitating a conversation with the patient that leads to making a decision that aligns best with that patient's preferences and goals. And the reality is most patients want to be involved in those treatment decisions, including patients with psoriasis. And what's more, shared decision-making is now being incorporated into reimbursement by some payers. So for example, Medicaid and Medicare require shared decision-making for the payment of some procedures. Not in dermatology at the moment, but in the future, that may be the case. And I think it underscores how important payers believe shared decision-making is. So we'll discuss treatment options, we'll discuss risk and benefits, we'll engage the patient in a conversation. Ultimately, we'll make a decision about a treatment to pursue. Then I step out of the room and tell Colleen, we have a patient with psoriasis, we're gonna start them on this medication.
So we want to encourage our patients to take a proactive approach to their care. We know that it takes a team to be successful when it comes to starting medication and maintaining medication. We want the patients to communicate with us, let us know how they're doing. We don't necessarily want them to let us know through a MyChart message what they did over the weekend, but we do need them to communicate things that count, like if they need a refill, we need for them to let us know ahead of time so that it's not last minute. If their pharmacy changes, if their insurance changes. We also need to pay attention to people that might fall through the cracks. These are people that, like older people who aren't tech savvy or, uneducated patients, or patients that don't have a strong support system. If you have a patient that's not bringing somebody with them to their appointments and you know that they're pretty much alone, then you need to spend more time with them and make sure that they're doing okay. You do want the patient to let us know how they're doing. We don't necessarily need to know everything, but we don't want someone to be totally miserable and then come in and say, well, I've been miserable. And we'll ask them, well, why didn't you call us? Well, because I had an appointment in 2 months. Well, we could have done something in those 2 months. So we want to make sure that the communication stays open as long as it's reasonable. Once the patient learns about this new disease that they have, we need to have resources for them to read, or websites like the National Psoriasis Foundation or the AAD brochures. We want to encourage them to read those reliable sources and try to stay off of the internet and let them know that everything that they see on the internet it's not necessarily all true. So we talked earlier, and we've been talking about, excuse me, all of these medications that we have for psoriasis. We have an abundance of paperwork in the office, and it needs to be organized. One way that I have learned to organize all this information is to have a box or a file and put each medication in each one. I take a rubber band, put it around the brochure, put an enrollment form inside, and that way, when Dr. Fernandez comes out of the room, he can just grab whatever he needs, take it back into the room. There are things that we need to talk to the patient about as far as paperwork before they leave the office. We need to gather information that we're not going to be able to get from them over the phone, such as a weight, blood pressure, TB test, the best phone number to contact them. Is it okay to leave a message? That's a big one. We ask for their email address and also ask them to answer their phone. That's a big one. You know, I will have people call and we'll get a message and we'll call them back in 5 minutes and they don't answer. And then they call the office all upset in a half an hour and say, you didn't call me. Well, yes, we did call you. You didn't answer the phone. So they need to know that they are not going to get their medication delivered if somebody doesn't call and reach them and talk to them. So that's a huge problem. And so we need to stress that for sure.
Okay, so the patient leaves, we send in a prescription, we send paperwork to a patient assistance program, and then we hear a decision. If we're lucky, that medicine is approved and the patient's on his or her way. However, as all of you know, it's really the insurance companies that dictate what's going to be approved or not. And it's not entirely uncommon to get a denial, and sometimes the patient assistance programs will not help. I personally still like to submit for the medication that the patient prefers, of course, assuming that you think it's a reasonable choice. I don't just let the patient pick. You have to think about comorbidities, all that stuff. But if whatever's reasonable and that's the patient's first choice, I like to submit for that. And I think that's really important in building trust and a good patient-physician relationship. But if it's denied, then sometimes you need to call the patient and have another conversation with them about, look, these are really our feasible options that will be covered by your insurance. And I have found that conversation is usually very easy and short. And we quickly come to a decision about the next medicine to pursue. I don't know exactly why, but I believe that it's because of that time that we spend during that initial encounter educating the patient, letting the patient know that we are working as a team for them, that we're not going to tell them what to do. That's my belief. I have no, real data to support that. And then eventually we're going to get a medication approved, and it's time for the patient to get started.
Okay, so before we start injection teaching, I'm going to base this on a patient that has a fear of needles, because we know that there are quite a few of them out there. And their first visit to the office to start their injections can make or break them. If they're not comfortable and they feel like they can't do it, then there's a good possibility that they're just going to say, forget it, and they're not going to continue with the medication. So it's important when they call, we always tell them when you get your medication at home, your first dose, bring it in to the office and we'll show you how to inject. It's always a good idea if we can tell them to bring a family member or a friend, just so that when we're teaching, there's, 4 ears are better than 2. So the first thing that I say when I go in is, we are going to go at your pace. We'll stay here as long as it takes to get you through this, and we're going to get this done, and it's going to be okay. They're already, this is something new, so they're already on edge about it, and then when you bring the needle aspect into it, then that just takes it to a whole new level. So what I'd like to do is start out by going over simple things. I don't jump right to the pen or the syringe, because that's just gonna, they'll never hear what you have to say after that. Everything else will be out the window. So I'll start with simple things. Look at the expiration date, make sure that it's okay. We're gonna talk about sites to inject, rotating sites, how to clean the site. All the basic things, including if you're not feeling well and it's time for your injection, please call the office and let us know. Tell us your symptoms so that we can talk to the physician and see if you should maybe hold that dose. It will have already been explained to them, about their immune system and everything, but just a reminder, if you have any questions at all, please call. Don't hesitate. We would rather have you call and have this work out than be at home and be scared. So when I get through all of the simple information, if there's a pen or a syringe, a training pen or syringe, I like to bring it in, show them with that, let them handle it, get it, kind of figure things out. And then I tell them, don't pick up the syringe until you're ready to inject. It's very easy to misfire, and the medication, as we all know, is very expensive. And I think most places will give you 1 misfire a year. So if you screw up more than that, it's not going to be covered. So it's very, very important. I always tell them what to expect. It's not going to be painless. You're going to hear a click, and your reaction is going to be to jump or to pull your hand away. And it's very, very important that you finish the injection before you pull it away. So sometimes what I'll do is I'll ask the patient, is it okay if I hold my hand over yours? And then that way, if you go to jerk it away, I can hold it there, and so that we can make sure that our injection is successful. If there are 2 injections for the first dose, I'll go ahead and inject one, and then I'll ask the patient if they want to inject the other one. If they are hesitant, I'll answer any questions, and I'll say, it's okay, you don't have to. I can do it again for you if you would like. And normally, as long as we're going slow and things are calm, they'll say, no, let me try. And then they will try, and 9 times out of 10, they'll be successful. Now, I always tell them, when it's time for your next injection, if you're not comfortable, if you forget what we went over, or you are just nervous about it, feel free to call the office. Come on back in. We'll supervise or show you again. The last thing we want for the patient to do is feel like they're alone. So Also, we will inject kids because most parents understandably would have a hard time injecting their children. So we tell them, just bring them in on the nurse schedule and we'll go ahead and inject. Also, people with physical disabilities, they may have a hard time injecting. I had a patient with RA, and she couldn't even hold the pen or the syringe. So she would come in all the time for her injections, and that's fine. That's what we're here to help people.
Okay, so then the patient started on medicine, and you're going to have a follow-up appointment. I typically, and I think most people who treat psoriasis typically will see patients back in about 3 months to assess if the medication is working. If, to me, it seems like the patient isn't getting a good response, and I'm confident the patient has psoriasis, so I don't start thinking about another diagnosis. What I want to try to find out is whether or not the patient is actually taking that medication the right way. And that's really tricky. You have to somehow find a way to ask the patient in a non-judgmental way if they're taking the appropriate dosing, if you expect to get a truthful answer. And I have found what works for me is trying to phrase the question sort of like, you know, I know when I have to take medications, it can be really hard to remember to take every dose because I'm so busy. How often do you miss doses of your psoriasis medicine? And hopefully that helps the patient not feel like, you know, we're pointing a finger at them or trying to place blame. And if you get a truthful answer and the patient really is missing a lot of doses, then we, in a non-judgmental way, try to troubleshoot what can we do, you know, given your life routine that may minimize missing those doses. And if we think we have an adequate plan, then I may give the patient a few more months on that medication to see if they take it appropriately, is it going to work? Sometimes we need to switch medications. Regardless of how the patient is doing, I do like to assess for any adverse events associated with the medications. We all know these medications can have adverse events. We do educate the patients about them initially, but it's, you know, to think they're going to remember every one, I think, is not really realistic. So we're the ones, of course, who need to know the ins and outs of the adverse effect profiles of these medicines, backwards and forwards. And if we can identify adverse effects, that's important, especially if we think they're due to the medicines, because adverse effects has also been shown to be one of the most important reasons why patients exhibit non-adherence. And then also, if the patient is doing very well, I like to stress the value of that regimen and to continuing to be adherent with taking the medicine the way they're supposed to take it. Now, there are, of course, barriers to doing everything that Colleen and I are talking about. And one of the most important barriers is the time it takes to educate and listen to these patients and answer questions. We've heard this over and over in the past 2 days, that the healthcare system today is pressing us more and more, all of us, to see more patients in the same amount of time. There are people who argue if you take the time to educate patients and listen to them and build that trust in that initial encounter, it will pay off in the future. It will pay off because there's a higher chance the patient will be adherent, and thus a better chance the patient is going to meet that treatment target and be under good control. And if they're under good control, that'll lead to less phone calls, less MyChart messages, less frequent clinic visits, and when they're in clinic, less time during those visits. So I do think there's value in taking that time. And then also in terms of shared decision making, some of the arguments currently are that, you know, physicians aren't really trained in shared decision making, and there aren't good validated physician decision aids when it comes to shared decision making. And those are valid points, but I think there's a lot of ongoing work to address these over time. And of course, importantly, not every patient is going to respond to the same strategy. Patients have different personalities, and I think going back to the importance of physicians, nurses, everyone in healthcare developing good, reliable teaching skills and communication skills. you may need to use different strategies to get through to different patients and help them understand.
To summarize our presentation, we know that non-adherence is prevalent and represents a major hurdle in optimizing care for psoriatic patients. Physician-nurse teamwork in educating and communicating with patients can effectively encourage adherence, and developing teaching and communication skills is critical, as individual patients may respond to different techniques. Thank you.